Hello, everyone, and welcome to NUR 491 Critical Issues and Strategies in Nursing. Please read your welcome note. Please read your 491 Critical Issues, Strategies in Nursing, your online instructor expectations. Keep abreast of what's in the news forum on a weekly basis. Know your rubrics for your discussion forums. My office hours, you can please disregard them. You can text me, email me, or call me at your convenience. There is examples of an APA reference page. There's an APA format template, APA formatum. There's questions and answering forum. You can use that. If you have a question, you can be guaranteed somebody else would have the same. You do have clinical observation requirements, 16 hours, preferably done in 4 weeks, 2 through 5. If you have any trouble of any kind, please reach out to me and let me know that you're having difficulties. And this week lectures are over PowerPoint presentations, chapters 1, 4, and 26. So I'm going to introduce you into nursing management. Changes in healthcare. So today's healthcare system is continuing to undergo significant changes. Costly life-saving medicines, robotics, virtual care, and innovations in imaging technologies, non-invasive treatments, and non-surgical procedures have combined to produce the most sophisticated and evidence healthcare ever, and the most expensive. Skyrocketing costs and inaccessibility to healthcare are ongoing concerns for employers, healthcare providers, policymakers, and public at large. A number of factors are forcing change on the healthcare system. Paying for healthcare. How America pays for healthcare. The United States spends more money on healthcare than any other country, and healthcare spending continues to rise with costs of $2.5 trillion in 2009. Consuming more than 17% of the country's gross domestic product, GDP, with the goal of providing access to health care to most U.S. citizens and containing costs. Congress passed a health care reform bill known as the Patient Protection and Affordable Care Act, the PPACA, that was signed into law March 23, 2010. While implementation of the bill is pending court challenges, the promise of providing adequate and affordable care to more Americans is on the horizon. Pay for performance. The 1999, the Institute of Medicine reported that 98% of deaths occurred each year from preventable medical mistakes, such as falls, wrong site surgeries, avoidable infections, and pressure ulcers, among others. By 2008, researchers learned that the effects of medical mistakes continue long after the patient leaves the hospital. In spite of numerous efforts to prevent mistakes, the cost of medical errors has continued to climb. Recent estimates put such costs at $19.5 billion annually. In 2008, the Centers of Medicare and Medicaid Services, the agency that oversees government payments for care, tied payment to the quality of care by changing its reimbursement policy to no longer cover costs incurred by medical mistakes. If medical mistakes occur, the hospital must absorb the costs. Thus, pay for performance became the norm, and performance is now measured by the quality of care. Demand for quality initiatives. In an effort to ameliorate medical mistakes, a number of quality initiatives have emerged. Quality management is a preventative approach designed to address problems before they become crisis. The quality movement actually began in post-World War II Japan, when Japanese industries adopted a system that W. Edwards Deming designed to improve the quality of manufactured products. The philosophy of the system is that consumers' needs should be the focus and that employees should be empowered to evaluate and improve quality. In addition to businesses in the United States and elsewhere, the healthcare industry has adopted total quality management or variations on it. Built into the system is a mechanism for continuous improvement of products and services through constant evaluation of how well consumers' needs are met and plans adjusted to perfect that process. Patient satisfaction surveys are one example of how healthcare organizations evaluate their customers' needs. Today, quality initiatives address all aspects of patient care and include government efforts as well as private sectors endeavors. Public reporting of healthcare organizations has emerged as a strategy to improve quality. To further that goal, the Agency for Healthcare Research and Quality, AHRQ, whose mission is to improve the quality, safety, and efficiency and effectiveness of healthcare, funds projects that address 3 quality indicators: prevention, inpatient quality, and patient safety. The Leapfrog Group. Efforts by the Leapfrog Group constitute one private sector initiative to address quality. The Leapfrog Group is a consortium of public and private purchasers established to reduce preventable medical mistakes. The organization uses its mammoth purchase power to leverage quality care for its consumers by rewarding healthcare organizations that demonstrate quality outcome measures. The quality indicators the group focuses on include ICU staffing, electronic medication ordering systems, and the use of higher performing hospitals for high-risk procedures. Leapfrog estimates that if these 3 patient safety practices were implemented, more than 57,000 lives could be saved, more than $12 billion could be saved, and more than 3 million adverse drug events could be avoided. Benchmarking. In contrast to quality management strategies that compare internal measures across comparable units, such as Leapfrog Group, benchmarking compares an organization's data with similar organizations. Outcome indicators are identified that can be used to compare performance across disciplines or organizations. Once the results are known, healthcare organizations can address areas of weakness and enhance areas of strength. Interestingly, one study found that hospital size didn't affect the ability of institutions to compare results. Evidence-based practice. Evidence-based practice has emerged as a strategy to improve quality by using the best available knowledge integrated with clinical experience with the patient's values and preferences to provide care. Similar to nursing process, the steps in EBP are identify the clinical question, acquire the evidence to answer the question, evaluate the evidence, apply the evidence, and assess outcome. Research findings with conflicting results puzzle consumers daily, and nurses are no exception, especially when they search for practice evidence. Hayter 2010 suggests that evidence falls into several categories: anecdotal, derived from experience; statistical, built from a scientific approach. Case study, an in-depth analysis used to translate to other clinical situations. Non-experimental design research, gathering factors related to clinical condition. Quasi-experimental research, design research, a study limited to one group of subjects. Randomized control trial, use both experimental and control groups to determine the effectiveness of an intervention. While all forms of evidence are useful for clinical decision making, a randomized control design and statistical evidence are the most rigorous. Magnet certification. The Magnet Recognition Program designates organizations that recognize healthcare organizations that provide nursing excellence. To qualify for recognition as a magnet hospital, the organization must demonstrate that they are promoting quality in a setting that supports professional practice, identifying excellence in the delivery of nursing services to patients, residents, disseminating best practices in nursing services. Becoming a magnet hospital requires a significant investment of time and financial resources. Research shows, however, that patient safety is improved when nurse staffing meets magnet standards. That's from Lake et al. Of 2010. Systems involving participatory management and shared governance create organizational environments that reward decision-making, creativity, independence, and autonomy. These organizations retain and recruit independent, accountable professionals. Organizations that empower nurses to make decisions will better meet consumer requests. As the healthcare environment continues to evolve, more and more organizations are adopting consumer-sensitive cultures that require accountability and decision-making from nurses. Magnet hospitals are those institutions that have met stringent guidelines for nurses and are credentialed by the American Nurses Credentialing Center. Characteristics common in magnet hospitals include higher ratios of nurses to patients, flexible schedules, decentralized administration, participatory management, autonomy in decision-making, recognition, advancement opportunities to retain the current workforce and attract other nurses. Healthcare organizations can take from the magnet program characteristics to improve work-life conditions for nurses. Encouraging nurses to be full participants and to share a vested interest in the success of the organization can help alleviate the nursing shortage in those organizations and in the profession. Evolving technology. Rapid changes in technology seem at times to overwhelm us. Hospital information systems, HIS, electronic health records, EHR, point of care data entry, POC, provider order entry, barcode medication administration, dashboards to manage, report, and compare data across platforms, virtual care provided from a distance, and robotics, to name a few of the many evolving technologies. Both fascinate and frighten us simultaneously. At the same time, communication technology from smartphones to social media continues to march into the future. It is no wonder that people who work in healthcare complain that they can't keep up. The rapidity of technological change promises, unfortunately, to continue unabated. Electronic health records, EHRs, represent a technology designed for rapid expansion, while banks, retailers, airlines, and other industries begin to rely on fully integrated systems to manage communication and reduce redundancies. Healthcare was still continuing to rely on voluminous paper records duplicated in multiple locations. Keeping data safe continues to worry healthcare organizations, consumers, and policymakers, but the benefits of integrated systems outweigh the risks. EHRs reduce redundancies, improve efficiency, decrease medical errors, and lower healthcare costs. Continuity of care, discharge planning and follow-up, ambulatory care, collaboration, and patient safety are just a few of the additional advantages of EHRs. Furthermore, fully integrated systems allow for collective data analysis across clinical conditions. Healthcare organizations or worldwide and support evidence-based decision-making with the federal government funding health systems to upgrade to EHRs. The current 12% of hospitals with EHRs is expected to increase. Virtual care. Virtual care, previously known as telemedicine and now more commonly called telehealth, has evolved as technologies to assess, intervene, and monitor patients remotely improved. Both communication technology, for example, audio and video, and improvements in mobile care technology contribute to the ability of healthcare professionals to provide care from a distance. Nurses, for example, can watch banks of video screens monitoring ICU patients, vital signs miles away from the hospital. Electronic equipment, such as a stethoscope, can be assessed by a healthcare provider in a distant location. Such systems are especially useful in providing expert consultation for specialty care. Robotics. Another technological advance is robotics. In the hospital, supplies can be ordered electronically, and then laser-guided robots can fill the order in the pharmacy or central supply and deliver the requested samples to nursing units via their own elevators more efficiently, accurately, and in less time than individuals can. Mobile robots can also monitor patients, report changes and conditions, and allow caregivers to communicate from a distance via a wireless connection to a laptop or smartphone. Robot functionality will continue to expand. Limited only resources and ingenuity. Communication technology. Just as rapidly as clinical and data technology are evolving, so are the communication technologies, changing forever the ways people keep informed and interact. Information, accurate or inaccurate, is disseminated with lightning speed, while smartphones capture real-time events and broadcast images instantaneously. Social media has revolutionized communication beyond the realm of possibilities from just a few years ago. Social media connects diverse populations and encourages collaboration, the exchange of images, ideas, opinions, and preferences in networking. Websites, online forums, web blogs, social blogs, wikis, podcasts, RSS feeds, photos, video content communities, social bookmarking, online chat rooms, microblogs such as Twitter, and online communities such as Facebook and LinkedIn. Similar to other enterprises, most healthcare organizations have an online presence with a website and social media sites such as Facebook, Twitter, and blogs. Units within the organization may have Facebook pages as well with staff who post on these sites. These opportunities for information sharing and relationship building also come with risks. Patient confidentiality, the organization's reputation, and recruiting efforts can be enhanced or put in jeopardy by posts to the site. Cultural, gender, and generational differences. According to the U.S. Census Bureau, the minority population in the U.S. increased from 31 to 36% from 2000 to 2010. The largest minority population is Hispanic, and that population increased to 50 million, 16% of the total population in 2010. The Asian population grew to 14 million, 5% in the same time, and the African American population stands at 42 million, 14%. The cultural diversity seen in the general population is also reflected in nursing. The Health Resources and Services Administration reports that 16% of nurses are Asian, African American, Hispanic, or other minorities, an increase from 12% in 2004. The gender mix found in nursing, however, differs from the general population, with men greatly outnumbered by women. Of the population, more than 3 million nurses in the U.S., only 6% are men. Although changes suggest the ratio is improving, the proportion of men to women has risen to 1 in 10 in the decades since 1990. Both cultural diversity and gender diversity challenge the nurse manager to consider such differences when working with staff, colleagues, and administrators, as well as medicating conflicts between individuals. Generational differences in the nursing population is unprecedented, with 4 generational cohorts working together, referred to as traditionals, baby boomers, Generation X, and Generation Y. Each generation group has different expectations in the workplace. Traditionals value loyalty and respect authority. Baby boomers value professional and personal growth and expect that their work will make a difference. Generation X members strive to balance work with family life and believe that they are not rewarded given their responsibilities. Generation Y, also called millennials, are technically savvy and expect immediate access to information electronically. Similar to dealing with cultural and gender differences, the challenge for managers is to avoid stereotyping within the generations, to value the unique contributions of each generation, to encourage mutual respect for differences, and to leverage these differences to enhance teamwork. Violence prevention and disaster preparedness. Sadly, violence invades workplaces, and healthcare is no exception. Moreover, nearly 500,000 nurses are victims of workplace violence. In addition, recent disasters, for example, the earthquake and tsunami in Japan, tornadoes in the US, and the threats of terrorism and pandemics challenge healthcare organizations to prepare for the unthinkable. Extensive staff training is required. Techniques include computer simulations, video demonstrations, disaster drills, and a clear understanding of communication system and the incident command center. A natural disaster, an attack on terrorism, an epidemic, or other mass casualty events may and probably will occur at some time. All healthcare organizations must be prepared to care for a surge in casualties while reducing the impact on patients and staff. Changes in nursing's future. Nurses will face many changes in the future, including an increasing demand for nurses as the population ages, a worsening shortage as nurses age, and recommendations for changes to practice and education. The aging population is surviving previously fatal diseases and conditions due to ever-evolving healthcare technologies. These patients often require ongoing care for chronic illnesses as well as for acute episodes of illness. Just as the population is aging and requiring more and more care, nurses too are growing older. The average age of the registered nurse is 46 years old. Although the number of RNs under age 30 is increasing at a faster pace than before, HRSA of 2011, slightly more than 3 million nurses are currently licensed as registered nurses in the U.S., and 85% of them practice full-time or part-time in the profession. Jobs for nurses, however, are expected to grow to 3.2 million by 2018, much faster than the average for all occupations, the U.S. Department of Labor of 2011. Also, with implementation of healthcare reform, increases the demand for nurses in primary care and acute care settings are expected. The Institute of Medicine's report on the future of nursing makes sweeping recommendations for nursing's future, including that nurses should be full partners with physicians and other healthcare professionals in redesigning healthcare in the United States. The IOM 2010, page 3. In addition, the IOM posits that today's healthcare environment necessitates better educated nurses and recommends that 80% of nurses be prepared at a baccalaureate or higher level by 2020. At the same time, the Carnegie Foundation recommends radically transforming nursing education. Its recommendations include focus on how to apply knowledge, not only acquire it. Integrate clinical and classroom teaching rather than separately. Emphasize clinical reasoning, not critical thinking. Emphasize formation rather than socialization and role taking. Even more change. What does the future hold for healthcare? Change is the one constant. Quality of care. Quality of care will continue to be monitored and reported with accompanying demands to tie pay to performance. Technology of care, communication, and data management will become more and more complex as computer processing power and storage capacity expand and equipment becomes smaller and more mobile. Access to care and how to pay for it will continue to drive policy and funding decisions. Everyone in healthcare must learn to live with ambiguity and be flexible enough to adapt to the changes it brings. Challenges facing nurses and managers. Every nurse must be prepared to manage. Specific training and management skills is needed in nursing school as well as the work setting. Most important, however, is that nurses be able to transfer their newly acquired skills to the job itself. Thus, nurse managers must be experienced in management themselves and be able to assist their staff in developing adequate management skills. Management training for nurses at all levels is essential for any organization to be efficient and effective in today's cost-conscious and competitive environment. The challenge for nurse managers and administrators is how to manage in a constantly changing system. Working with teams of administrators and providers to deliver quality healthcare in the most cost-effective manner offers opportunity as well. Nurses, unique skills in communication, negotiation, and collaboration position them well for the system of today and for the future. Nurse managers today are challenged to monitor and improve quality care, manage with limited resources, help design new systems of care, supervise teams of professionals and non-professionals from a variety of cultures, and finally teach personnel how to function well in the new system. This is no small task. It requires that nurses and their managers be committed, involved, enthusiastic, flexible, and innovative. Above all else, it requires that they have good mental and physical health. Because the nurse manager of today is responsible for others' work, the nurse manager must also be a coach, a teacher, and a facilitator. The manager must work through others to meet the goals of individuals, of the unit, and of the organization. Most of all, the manager must be a leader who can motivate and inspire. Nurse managers must address the interests of administrators, colleagues in other disciplines, and employees. All want the same result: quality care. Administrators, however, must focus on costs and efficiency in order for the organization to compete and survive. Colleagues want collaborative and efficient systems of care. Employees want to be supported in their work with the adequate staffing, supplies, adequate, and most of all, time. Therein lies the conflict. Between all of them is the nurse manager who must balance the needs of all. Being a nurse manager today is the most challenging opportunity in healthcare. This book is designed to prepare you to meet these challenges. What you know now. Healthcare is radically changing and is expected to continue to change in the foreseeable future. The tension between providing adequate nursing care and paying for that care will continue to dominate healthcare decisions. Reducing medical errors is the goal of quality initiatives. Cultural, gender, and generational diversity will continue to shape the nursing workforce. Evidence-based practice will guide nursing decisions into the future. Electronic health records, robotics, and virtual care are just a few of the many technologies continuing to evolve. Expansion in communication technologies will continue to offer opportunity and challenges to healthcare organizations. Threats of natural disasters, terrorism, and pandemics require all healthcare organizations to plan and prepare for mass casualties. The nurse manager is challenged to manage in a constantly changing environment. Leading, managing, following. Managers and leaders manage, manager, leader, supervisor, and administrator are often used interchangeably, yet they are not the same. A leader is anyone who uses interpersonal skills to influence others to accomplish a specific goal. The leader exerts influence by using a flexible repertoire of behaviors and strategies. The leader is important in foregoing links, creating connections among the organization's members to promote high levels of performance and quality outcomes. The functions of a leader are to achieve a consensus within the group about its goals, maintain a structure that facilitates accomplishing the goals, supply necessary information that help provide direction and clarification, and maintain group satisfaction, cohesion, and performance. A manager, in contrast, is an individual employed by an organization who is responsible and accountable for efficiently accomplishing the goals of the organization. Managers focus on coordinating and integrating resources, using the functions of planning, organizing, supervising, staffing, evaluating, negotiating, and representing. Interpersonal skill is important, but a manager also has authority, responsibility, accountability, and power defined by the organization. The manager's job is to clarify the organizational structure, choose the means by which to achieve goals, assign and coordinate tasks, developing and motivating as needed, evaluate outcomes, and provide feedback. All good managers are also good leaders. The two go hand in hand. However, one may be a good manager of resources, but not much of a leader of people. Likewise, a person who is a good leader may not manage well. Both roles can be learned. Skills gained can either enhance either role. Leadership. Leadership may be formal or informal. Leadership is formal when practiced by a nurse with legitimate authority confirmed by the organization and described in the job description. For example, nurse manager, supervisor, coordinator, case manager. Formal leadership also depends on personal skills, but it may be reinforced by organizational authority and position. Insightful formal leaders recognize the importance of their own informal leadership activities and the informal leadership of others who affect the work in their areas of responsibility. Leadership is informal when exercised by a staff member who does not have a specific management role. A nurse whose thoughtful and convincing ideas substantially influence the efficiency of workflow exercising leadership skills. Informal leadership depends primarily on one's knowledge status, for example, advanced practice nurse, quality improvement coordinator, education specialist, medical director, and personal skills in persuading and guiding others. Traditional leadership theories. Research on leadership has a long history, but the focus has shifted over time from personal traits to behavior and style to the leadership situation. To change agency, the capacity to transform, and to other aspects of leadership, each phase and focus of research has contributed to managers' insights and understanding about leadership and its development. Traditional leadership theories include trait theories, behavioral theories, and contingency theories. In the earliest studies, researchers sought to identify inborn traits of successful leaders. Although inconclusive, these early attempts to specify unique leadership traits provided benchmarks by which most leaders continued to be judged. Research on leadership in the early 1930s focused on what leaders do. In the behavioral view of leadership, personal traits provide only a foundation for leadership. Real leaders are made through education, training, and life experiences. Contingency approaches suggest that managers adapt their leadership styles in relation to changing situations. According to contingency theory, leadership behaviors range from authoritarian to permissive and vary in relation to current needs and future probabilities. A nurse manager may use authoritarian style when responding to an emergency situation such as cardiac arrest, but use a participative style to encourage development of a team strategy to care for patients with multiple system failure. The most effective leadership style for a nurse manager is the one that best complements the organizational environment, the tasks to be accomplished, and the personal characteristic of the people involved in each situation. Contemporary theories. Leaders in today's healthcare environment place increasing value on collaboration and teamwork in all aspects of the organization. They recognize that as health systems become more complex and require integration, personal growth who perform the managerial and clinical work must cooperate, coordinate their efforts, and produce joint results. Leaders must use additional skills, especially group and political leadership skills, to create collegial work environments. Quantum leadership is based on the concepts of chaos theory, see Chapter 2. Reality is constantly shifting and levels of complexity are constantly changing. Movement in one part of the system reverberates throughout the system. Roles are fluid and outcome orientated. It matters little what you did, it only matters what outcome you produced. Within this framework, employees become directly involved in decision making as equitable and accountable partners, and managers assume more of an influential facilitative role rather than one of control. Quantum leadership demands a different way of thinking about work and leadership. Change is expected. Informational power. Previously, the preview of the leader is now available to all. Patients and staff alike can assess untold amounts of information. The challenge, however, is to assist patients uneducated about healthcare how to evaluate and use the information they have. Because staff have access to information only the leader had in the past, leadership has become shared activity, requiring the leader to possess excellent interpersonal skills. Transactional leadership. Transactional leadership is based on the principles of social exchange theory. The primary premise of social exchange theory is that individuals engage in social interactions expecting to give and receive social, political, and psychological benefits or rewards. The exchange process between leaders and followers is viewed as essentially economic. Once initiated, a sequence of exchange behaviors continue until one or both parties find that the exchange of performance and rewards is no longer valuable. The nature of these transactions is determined by participating parties. Assessments of what is their best interests. For examples, staff respond affirmatively to a nurse manager's request to work overtime in exchange for granting special requests for time off. Leaders are successful to the extent that they understand and meet the needs of followers and use incentives to enhance employee loyalty and performance. Transactional leadership is aimed at maintaining equilibrium or the status quo by performing work according to policy and procedures, maximizing self-interest and personal rewards, emphasizing interpersonal dependence, and routinizing performance. Transformational leadership. Transformational leadership goes beyond transactional leadership to inspire and motivate followers. Transformational leadership emphasizes the importance of interpersonal relationships. Transformational leadership is not concerned with the status quo, but with effecting revolutionary change in organizations and human service, where